Well, gastroesophageal reflux really is simply as it sounds, it's passage of contents from the stomach into the esophagus. And gastroesophageal reflux is different to gastroesophageal reflux disease, because that is when there are symptoms associated with gastroesophageal reflux. Because we all get gastroesophageal reflux, there is a certain amount of time during the course of a day when we all do, and that's the same for children. But whether or not it becomes troublesome and gives you complications is what we're really interested in. And so trying to differentiate between what is reflux and what is disease is at the heart of any clinician really that is working in this field. Well, reflux can be associated with all sorts of symptoms, really. Obviously, vomiting is a pretty cardinal symptom, and depending on the age of your child is really when there's different advice, because certainly in a newborn, if you're vomiting and the colour's green, then that becomes a potential surgical emergency, and you certainly need to have very specialist advice sought very early. Around the age of 4 weeks, if the child starts to become vomiting very forcefully, then there can be other potentially surgical diagnoses, and one such condition called pyloric stenosis. But when the baby has a normal rate of feeding and yes is losing weight or is getting malnutrition as a result of that, then those are when the symptoms and signs of reflux need to be taken very seriously, because poor weight gain, and because in very young children, pain is not something that they can often tell us about. Certainly in the older child and certainly the teenager, it becomes a little bit easier. Certainly in the teenager, they can have the very classical symptoms that adults have, and that is burning here in the chest. But in children, smaller children, that is harder for them to be able to elicit that and tell us about it. Wheezing, chest infections are also, many other things can cause that in children, but that can also be a sign of gastroesophageal reflux. And asthma as a new diagnosis also has to be thought about whenever there are chest symptoms, as to whether or not really reflux is at the cause of it all. So it can be quite a tricky diagnosis to get early on. But certainly I would say that irritability, poor feeding, poor weight gain, recurrent chest infections in very smaller children, certainly over the age of 1. Under the age of 1, many other conditions can be the cause. You should still be seeking clinical help. In the ages of about, say, 1 to 5 years of age, the most common symptoms of gastroesophageal reflux disease, that's when reflux is starting to cause a problem, is mainly regurgitation, vomiting. They can complain of abdominal pain, losing weight, and actually refusing to feed. And it can cause all those symptoms. It doesn't necessarily interfere with growth either, but they can also become aversive to food, because every time they take food, it's painful, even though they might not be able to tell you that. So without doubt, weight loss is a very, very cardinal sign around the ages of 1 to 5. But as I said, when you get a bit older, children and adolescents, they're more likely to complain of the chest pain or heartburn, and they might still vomit on their breath. And those are easier, or they burp a lot. Those are easier symptoms to be able to begin to make that diagnosis and various tests that we do. Coughing at night when lying flat in children, that's also something that might raise suspicion of reflux. And unexplained chest infection, sore throat, and sometimes chronic ear, nose and throat problems. And if you're finding that compared to your your friends' children, that they're going to the dentist a lot more than they normally do for erosions, and often the dentist will potentially highlight that to you, that dental decay, because acid burns away the teeth. So obviously that's in children that have developed teeth. But that can be a cardinal sign as well of gastroesophageal reflux disease. There isn't one particular single test that can diagnose it, and it's absolutely the taking a story by an experienced clinician, particularly the under ones, because there's so many different reasons as to what could cause reflux, reflux-like symptoms in the under one. But as in the gastroenterology and surgical fields, we tend to use studies such as, in order to make sure there's nothing anatomically wrong with the baby or the infant or the child's intestinal anatomy, then we would use something called an upper gastrointestinal contrast series, and that's when we swallow barium-like fluid, which then outlines the appearance of the intestinal tract to make sure it's all in the right order. Because there is a condition called malrotation where that can predispose children to vomiting, and that is a completely different treatment is needed as opposed to the normal reflux treatment. To actually get our gold standard, if you like, the way we diagnose it is by having a small probe in the nose, which is passed by an experienced team, which passes through the nose and into the lower part of the esophagus. The esophagus runs from the back of the mouth right the way down to where the hard part of your chest bone finishes, and that's where the junction is between the esophagus and the stomach. And this probe is used then to measure over a 24-hour period. It's connected to a very small computer which sits with the child. And then that measures over a 24-hour period as the child eats and drinks and sleeps normally, measures the amount of acid that goes up and down. And different types of probe can measure different things. We can also look at gas and just liquid in general. But it's a very prolonged test, so it goes on for up to 24 hours, but gives us a really good picture of what's going on in that child's lower esophagus, which of course that is where the problem is, because normally there's an effective barrier which stops food and liquid from the stomach by going into the esophagus. So yeah, that's one of the key tests to measure gastroesophageal reflux. We can also do more invasive tests which involve an endoscopy, which is a camera going through the mouth and into the lower esophagus. And certainly that will tell us whether there's inflammation there, and we can take biopsies as well, which can rule out certain other causes such as milk allergy potentially as the cause for some of the symptoms. But of course that involves an anaesthetic usually, so it's really at the end stage of our diagnostic workup. Well, there are huge numbers of treatment options, and again, it really depends on how bad the symptoms are, whether you really feel like you've got the diagnosis absolutely right. And I think for very small infants, and really all children, ultimately to begin with, it's all about modifying various things within the lifestyle of that infant, and the first thing normally is a change of milk, and it may be that breastfed or changing formulas are altered, reducing the amount of feed volume. Sometimes some babies are just fed too much, and looking at taking dairy out of the equation. Those kind of things are very common early steps in feed modification. Adding in solids if it's the correct time to do that, can have quite dramatic changes. And thickening the milk. So if the milk's too thin, then you'll find that a thickener can often keep thin milk down in the stomach and stop reflux. And then if all of those, together with positioning, I think lying flat is also a proponent of reflux, particularly in very small infants, which is why you'll often have baby chairs which are slightly elevated, but raising the head of the bed, also a very effective way of improving nocturnal symptoms. And again, in adolescence, if there are children are overweight, for example, then and all the other lifestyle modifications that you would for an adult, if the teenager is participating, then you want to change those. But acidic foods, that kind of thing. But then when it comes to those modifications and they haven't really helped, then we go down the route of medicine. So that can be antacid type of medicine, which has the sort of Gaviscon type formulas, which can be very effective and also act like a milk thickener as well, sort of antacids. And then we come into drugs that affect the production of acid or block the acid's effect within the stomach, so that it produces a non-acid like reflux. It doesn't really take the reflux away. And there are drugs such as ranitidine, and we call them proton pump inhibitors, and such as omeprazole or lansoprazole, and those are very effective. Long-term use of them is controversial still, I think, in children, and there does seem to be a growing body of evidence looking at problems with recurrent chest infections with children, possible bone fractures, particularly with the proton pump inhibitors. And you need to monitor, if you're on for it for prolonged periods, then we need to monitor electrolytes such as calcium and magnesium to make sure that they're all within the normal limits. And when all of those, if all of those are either you don't want to stay on medicine for too long and there's a definitive absolute diagnosis of gastroesophageal reflux, then surgery is kind of the end stage of that treatment plan. And the surgery for gastroesophageal reflux is usually in the form of something called a fundoplication. And this is equivalent really to creating a valve, if you like, at the lower end of the esophagus. And it's a valve which uses muscle from the stomach itself, and it acts like a one-way valve. It's not something that we take lightly, because it's classified as a major operation, but it's one which is done with keyhole surgery usually, and in virtually all cases it can be a keyhole operation, and the patient is normally, the child is normally able to feed that night or the following day. And it enables the strengthening of all the normal mechanisms that the rest of us take for granted, which help to keep that pressure high in the lower part of the food pipe or the esophagus. And it's very important to get that diagnosis right. So certainly for any parent that's been offered that, it's absolutely fundamental. This is a very careful decision, not only by any medical teams together with the surgical teams, but it's a very it's important decision to get right, because if the diagnosis is wrong, then the operation is very likely to fail. It's really important that parents have a proper counselling and education before any such surgical procedure takes place.